Thanks for having us. Thanks for coming out on a rainy day. Very excited to be here. What Ben and I are going to chat about is how Heidi has been used to really kind of transform workflows using our suite of products with a particular focus on primary care. So hopefully this works, good. We're just going to run through a quick sort of overview of our mission and how we approach that, what that means from a kind of product suite perspective. And then we're going to zone in on one of our key products, which is why Ben is up here, to walk you through our new evidence feature, which came out recently. And we've been piloting with the Modality group with some really great results, hopefully not just flashy numbers on a slide, Tom. Cool. And then we're going to jump into a live demo, which hopefully will work. Who are we? So my name's Dr. Hannah Allen. I'm a GP by background. I've been in the digital health space and telemedicine AI space for the past 10 years. Previously been at Babylon Health, been a founder, consulted with lots of startups. And then joined Heidi about 2 years ago as Chief Medical Officer. I'll let Ben briefly introduce himself.
Well, yeah, I'm Ben. I was formerly a vascular reg, doing a bioinformatics PhD about DVTs, no less, at Imperial, but at the same time started a medical knowledge startup that was acquired by Heidi Health, so now work with the team on the evidence product there.
Brilliant, thank you. So we have a very audacious mission. We want to double the world's healthcare capacity, but really critically, without dehumanizing it. And when often we think about dehumanizing, I think about, in clinical practice, turning away and typing and not focusing on that patient in front of me. There are lots of other aspects to really kind of true critical human healthcare, trust, compliance, governance. But actually on the ground, it is often that ability to be able to focus on that patient in front of us, to be able to look a patient in the eye, to be free from all of the distractions that modern day healthcare poses to us. Tom and the panel were referring to all the distractions that happen in our everyday clinical practice, pulling us away from the key person in that room, the patient, right? So actually, how do we build an infrastructure that allows us to focus solely on the patient in front of us? And that's what we're really focusing on at Heidi. So what does that actually mean? And how do we execute on that? So we're focusing on building tools that remove the distraction that allow us to focus on patients. We started with the Scribe, which a lot of people in this room may know the Scribe, used by 1 in 2 GPs, and we'll go into a little bit more data on that shortly. But really does much more than that. We're moving into this kind of more autonomous workflow space where we're able to kind of predict what we might need or be able to support with the tasks that fall out of that consultation. So just so much more than kind of voice to text. We also have an intelligent, autonomous comms product, which allows us to communicate with patients outside of that immediate interaction during the consultation. And then we have the remote, which Ben is kindly demonstrating up here. If you want to have a closer look, do come over to the stand afterwards. But we know that care happens not just in those isolated consultation rooms. It happens in corridors. It happens in ambulances. It happens in nursing homes. It happens outside of that immediate space. So we need to allow clinicians to be technologically and physically untethered from a computer, right? And that's what the remote allows us to do. But I've missed out evidence here. And Ben is going to walk us through a really great example of how we use evidence day to day and how it's being implemented in practice at Modality. And we're going to touch upon a little bit on the impact that we're having as an AI care partner, bringing all of these sort of suite of products together into one orchestration layer, allowing us to execute on all workflow tasks, clinical tasks, and operational tasks at scale across primary and secondary care as well. Ben.
So I think primary care really stands to benefit from innovations such as evidence. You're seeing at the front door undifferentiated conditions, things that you may not be used to seeing very often. And then there's the fact that, moreover, medical knowledge is doubling every 73 days. We're in this incredible era of more and more research being done. It's faster to do, genome sequencing, incredible stuff. And yet how are any of us supposed to stay on top of all of the latest guidelines and stuff while still doing the daily job and seeing those patients in that very short amount of time that's allotted? So large language models offer an amazing way for clinicians to access all of that medical information at the point of care. The problem with the generic commercially available models is that either they're not providing you references to that underlying source material that's being used, you're relying on those internal language model pre-trained weights. That's not very defensible. So what we think that, or the hypothesis behind evidence, is to give clinicians a single point of access to the resources that you use and trust as part of their daily practice. So it's ad-free, just like you know how in the States we have open evidence and Doximity that are making their money from pharma influence, trying to influence clinical decision-making and pharmaceuticals. Like, there's none of that with Heidi Evidence. Similarly, maybe next slide actually, Hannah. Oh, we'll move on to talk about the impact in the UK, in fact.
Thank you. So, so evidence is a critical part of our kind of orchestration layer, and we're starting to see some really exciting numbers and data coming through. And we can tell you a little bit more about that in a second. But we also released our impact report to the UK a couple of weeks ago. So do have a look at that. You can download it online by requesting access. We've seen a huge impact since coming to the UK market about 2 years ago. So we're now supporting just shy of 2 million consults every month. We've released a huge amount of clinical capacity, 4 million clinical hours returned to the NHS, we've estimated, and we've got huge scale with about 1 in 2 GPs using us. So really significant footprint in primary care, which is really exciting to see. But most importantly is actually the impact on our clinicians on the ground. So across the modality patch, we saw that 61% reduction in out of consultation documentation, significant improvement in morale and symptoms of burnout, which is ultimately, you know, what I really care about as a clinician is keeping clinicians happier in the workforce, retaining talent for longer.
So we did a small focused pilot with Modality to look at the ways that evidence actually impacted clinical practice. So immediately, and something that's really nice to see, is that we were able to replace like 2 to 3 different tools that GPs were using as part of their daily practice. So again, as Hannah was saying earlier, like maintaining that focus on the patient is what you're doing by doing that. Obviously, the benefit that Heidi Evidence can be launched from within that scribe consultation as well, like keeping it really focused. Similarly, there's some time savings, 30 seconds to 2 minutes per consult. We know how Tom feels about that, but nonetheless, this is what's recorded in the pilot. The really important figure to me is that greater than 90% of the users in the pilot said it improved their confidence with the clinical decisions that they were making. And that's actually just saving you that mental time going home at the end of the shift when you're thinking about all the patients you've seen that day and have you done everything that you should have done for those patients. Right, we're going to try and move on to a live demo, and from the floor, just to prove this is live, does anyone want to ask a question? I've got one prepared if everyone's feeling shy, but we can send the mic around.
Surely one of the clinicians will have one. There we go.
Here we go.
Do you want to? Come on, Devin, what have we got?
Oh, yeah.
Tom, can you hear that? Brilliant. I was on call yesterday and a patient sent in an online request saying, would it be possible to be referred to have yearly mammograms rather than 3 yearly because I'm on HRT over 60?
What's the clinical guidance around yearly mammograms for a patient who's on HRT and is over the age of 60? They're requesting it, and I'd like to know if it's something we can organise. Nice. Okay. Always good when that bit works as well. I getting ahead of myself. Let me walk you through the setup of what we've got here. So it's like quite a recognisable chatbot interface, right? There are a few things we can do. Linking a specific patient consultation or a patient themselves, and thinking about things like you've seen your patient before in Heidi and you want to summarise everything that's happened up to that visit before they come in. We can also add additional files, think about things like blood tests that may be relevant from recent appointments. Then we have the sources, which we've curated into a series of different tabs here to make it easy to select. Usually the one I use for like the highest quality and most authoritative literature is the Literature and Guidelines tab. We have this feature called the library, which allows you to create your own lists of sources that you would use as part of your normal daily practice and add those to be accessed by the models in the background. Moreover, you can upload PDFs, local guidelines, even link a SharePoint with all of your PCN, local guidance, ICBs, etc., etc. And finally, we have specific partners that we're working with. So that would be NICE CKS and BMJ Best Practice, lots of other exciting ones coming soon. So we'll send this off, see what comes back. Straight away, what you start to see with the model is that the searches get decomposed into some LLM searches to maximize the amount of literature that we're returning in the search. Next, we start to see the sources populate. And if I expand these, you'll see that these are like highly authoritative resources that are being used. We put the key points of the response in a blue box straight at the top, so it's quick and easy to see. Moreover, we encourage the model to produce tables. None here yet. Every time we make a medical statement, we provide a reference to that underlying source material. And that is incredibly important because you need to know that we're not relying on that language model. The summarization of information that already exists is intrinsically a much less risky task for a language model to do. And in fact, they're very, very good at it. And it's that reliance on summarization rather than de novo generation that makes our rates of hallucination very, very low. There we go, a table, fantastic. We provide all of the references at the bottom of the response as well as in line. And if you want to review one of these references, let's say this one, you can click through to the underlying source material and you can verify the information that is in the underlying document. When you come back, you'll see there's this counter. What's that counter doing? It's recording your daily micro-learnings that you're having as a GP, searching various bits of information up. And we make that highly exportable in your CPD function. You can see just from doing demos alone, I've clocked up 185 hours of CPD now. Fantastic. Make sure to upload that to my vascular portfolio if they'll still have me. And it's super easy to do. You can just export this as a CV. I think...
How did that stack up, Devin?
So the reason why I shared that example actually is I think quite often we know the answer, but when we're responding to the patient, what I find that this kind of tool helps me with is being able to, so when I used it, it did flag, well, I'm making some assumptions here that this patient doesn't have an increased genetic risk, for example, so it can prompt you to go back to the patient and say, can I just clarify a few things before I give you a final answer? But I think it also can be really useful to say, this is the evidence behind the position and not just a computer says no.
Yeah.
And even signposting patients to those resources so they can go and read them in their own time as well. Which leads me to another great thing that I think we're about to be kicked off. But, another great thing we can do is if you want to make a load of information that you've just searched digestible to a patient, you can export that as a PDF and print it from within the evidence function, which is why we're actually changing it to be called Heidi Work, because this can do a lot more for you than just searching up clinical evidence. We can create documents, we can one-shot flow diagrams for new care pathways that you might be creating, and lots of other functions.
So all very exciting. Thank you so much for having us. We better make a move now, but please come over and have a play and ask us the tricky questions. We'll be over at the stand. Thank you.